welcome. It must be everybody quieted down. I want to welcome everybody to the Vaccination Q&A session with Dr. William Atkinson. I feel really honored that we have Dr. Atkinson here. I'll go into that in just a second. First, I have to give you I want to remind you of our goal of this summit is that we're going to empower immunization stakeholders and arm them with information and tools to help them champion immunizations throughout Texas. And just a few housekeeping items. I want to let you know the bathrooms are off to the right, and please silence your cell phones. But feel free to tweet on social media during the presentations using the hashtag TXIZ14. Dr. Atkinson, as I'm sure all of you know, is like the decades-long CDC answer man for immunizations. He has put together, through the course of the last several decades, many resources that we all use, most notably the Pink Book, and has been really a prominent and quick responder to immunization questions through the CDC info line, and now at immunize.org he is the Ask the Expert by and large. I'm sure he shares that with a few other individuals, but I first remember going to my very first national immunization conference and sitting as you all are in the audience and having lots of difficult questions which he seemed to know all the answers to. So my goal, I was on the planning committee for this conference, and I was so excited to bring Dr. Atkinson here because my goal is that each one of you can become the answer person for your organization on immunization questions. Dr. Atkinson, throughout his career, has done a wonderful job of sort of translating those volumes of ACIP recommendations into some rules to apply and some guidance. And I'm hoping that today he'll point us to those resources, that he will empower you all to be able to use those resources effectively, and to help each one of you become someone in your organization that others can turn to when they have those difficult questions. So please welcome Dr. Atkinson. I have a microphone here, and I have a microphone here, and I have some pre-prepared questions in case the audience members don't have very many. But I thought really if you could start, Dr. Atkinson, with just what are some of the resources that we ought to all have on our computer desktop or our physical desktop?
No, in your brain.
In our brain.
More helpful there. That way you don't have to go open your laptop. I have said it many times over the past 20. Those of you I wouldn't be so presumptuous that you all know who I am. I was at CDC for 25 years. 23 of those were in 3 different iterations of what is now the National Center for Immunization and Respiratory Diseases. I was there when it was a division, and just after Dr. Hinman left, so that gives you an idea of how long ago that's been. And I started out doing measles. I was working out, that's why I actually was in New Orleans for a while, and then I got tired of that, and not tired of New Orleans, but I went back and took the measles job in 1989. It was when I went back to Atlanta, and those of you who've been in the business for a while might remember that 1989, 90, 91 are infamous because that was the big measles resurgence that occurred, and I jumped right into the middle of that and worked on measles for 5 years. And what I learned during my measles time led me to where I am today. Is that what I learned from that is obviously we had programmatic issues, because the problem, if you remember, the measles resurgence of 89, 90, 91 was primarily fueled by a large population, including several here in Texas, of unvaccinated children younger than 5, basically. It was preschool-age children who had enormous attack rates, and they weren't vaccinated. And we had terrible. At the same time, we were having single-dose vaccine failure issues in colleges. So we were having college outbreaks among one-dose people, small outbreaks, but big to handle. If you ever remember those, they have to go in and give 10,000 doses at UT or something for, half a dozen cases in a dorm. But the really big problem was the fact that we had very, very high attack rates in large urban areas and had these big outbreaks, including Houston and Dallas and Los Angeles and New York and Philadelphia, and a lot of most big cities had these outbreaks eventually. What I learned, besides the fact that that led to the VFC program, by the way, that's why we have a VFC program. That was one of the main instigators of doing it, was that big resurgence because of access and funding. Then what really then happened, what I also learned, besides when we fixed the funding problem and VFC came around, the problem is that I learned that a lot of providers didn't know what to do. They didn't know what to do. And at that time, in 1994, 95, CDC was not really using its bully pulpit and was not doing any training. And I had been on the faculty at Tulane and had developed a vaccine course for Tulane graduate students, and I brought that course with me when I came to Atlanta in 1989, and it became the EpiVac course that it evolved into the epidemiology and prevention of vaccine-preventable diseases, and we put it on the air and put it on satellites and put it on DVDs and tapes and everywhere else, and we did the book. The pink book was developed because people didn't like to take notes. It had, if you remember, it had all the slides. That's what it was for. It was a companion, and it followed the same order that we did these. Remember, they were 16-hour-long programs, 4 hours at a time, 3.5, 4 hours at a time over 4 weeks. Those were really fun to do, and they don't do those anymore. If you haven't noticed, those the days of satellite broadcasts apparently ended when I left 2 years ago. And now, apparently, everyone's attention span is now only 2 minutes long. So that's what they're doing. So that's how I got into the answer business and got into the teeth training business, is because that's why I did what I did for so long, and that's why I ended up here, is because there was nobody doing any training. And so I kind of took over the training program for the immunization program, and the rest is forgotten by now. Anyway, so I've answered 100,000 questions during my. I came up with NIP Info, that email thing that you probably have. Some of you have sent emails to. I did that. I did almost all that for almost 20 years. I figured I'd probably answer about 100,000 questions. That's why it appears that I know everything, because I was convinced after a while that there were no new questions, that there were only the same question asked in a different way, so I got really good at answering those questions. But in fact, that's not true. That's really not true, because there are new questions, because there's all kinds of scenarios that happen. So anyway, that's how I got to what I'm doing and why I'm standing here with you. So I have no script. I have no idea what's in your brain. If you have questions on any vaccine topic, this is like, I was thinking about this morning. It's like remember county fairs, remember them? Where they have these booths where this guy sits on a platform and people take balls and throw it at the target and try to dunk the guy. Well, I feel like the guy on the platform, because I have no idea what you're going to ask me. If you don't have questions, I do, because I'm still answering a lot of questions, and we still get a lot of questions. I get them at IAC now instead of at CDC, so let her go. If you have questions on something you've heard today or something that happened to you last week, or don't ask me anything about the election, but go for it. I mean, it's your hour, so you're 40 minutes, so go right ahead.
Oh, you were speaking about the EpiVac courses in the Pink Book. What are the delays? Do you know on that?
Yes, I do.
When's another series of EpiVac?
Yes, I do. I'll tell you exactly what happened. When I was there, I was the principal writer and editor for 12 editions of that book. And I had been there for so long, I knew all the subject matter experts, and I didn't ask anybody. I just wrote it, and if I had a question, I would go to one of the guys that I knew that I'd known for 5 years, and I'd say, is this right? And they'd say, yeah, that's right, and then I would just send it to the publisher and it'd get published. It did not. For 12 editions of that, and see, the cool thing was, this being recorded, the cool thing was that everybody at NIP, at CDC, assumed that the book had been cleared. But in fact, none of it was ever cleared. I just wrote it, and we did it. And well, Well, no, just let me put it in the caveat. The caveat is that if you've been in an organization as long as I had, I've been there for 20 years, I've been through all of the development of all this policy, because I was very active with ACIP. You might have heard LJ blaming me for the schedule with all the tiny writing in it, all that, because I was involved in that. So I was involved in all of these work groups and knew all the discussions, and have attended ACIP meetings for 20 years. And so you learn after that, and plus being out on the road in front of people, if you say things that are wrong, that stuff gets back to the people that supervise you. If you're out there saying stupid things or embarrassing people or making incorrect statements or, or talking to the press, that kind of stuff gets back. And I had this printed document that was out there for anybody to read, and if there was error, and sometimes there were little things in it that weren't really big technical things. So I got away with it because nobody ever really found anything wrong with it. Because I knew, after you've been doing the policy for so long, you knew what you can, particularly in a big government system, you'd find out what you can and cannot say. There are things you can say and things you cannot say. And so I knew what I could and could not say. And we always sent one to Walt. Remember, Walt Ornstein was my director for many, many years. While I was there, we always sent him one. We sent everybody one. They said, what a great piece of work. They never knew how it got done. There weren't any mistakes. That's the key. You got to know. I knew what I could and could not say, and it was all taken from ACIP statements. It's basically the cliff notes of ACIP statements is what that thing is. And so I just did it, and we got it published, and it got out there, and it was quick, and it was painless. And it wasn't painless because it took a lot of work to do all that stuff. But now, when I left, the people who worked for me, who are now still there, don't have the same attitude, and CDC is changing. CDC is a different place now, and they've buttoned up, and the people who work there now don't have the same. They can't get away. They can't get away with stuff. And as soon as I left, immediately the book went into clearance. And it's 22 chapters. You know what that thing looks like. And they had to send it to each. I was just told by the new editor, each chapter was reviewed by 3 people, meaning that you've got to consolidate the comments on more than 50 people to get that thing done, and it's been cooking now for 2 years. And so they thought they'd have it done this year, but it might come out next year. But it's because it got absorbed into the CDC approval process, which is something I never did, which is why it was quick, because we had to turn it over quick, because it had to be out there. It had to be in your, if you remember, think back on 10 years, it had to be, if it wasn't in your hands, when that broadcast began, we got all kind of hell from you. Where's my book? You had to have your book. And so we were under a major time constraint to get the book published and to you, so you would have it to make notes in when you went to the course. That was what it was about. So that's why, so the one way to do that is not have any courses. They're still doing a few live courses, but the broadcast courses apparently are dead and gone now. So anyway, there's a man with a book right back there. That's the last one I did. That's the 12th edition. So I don't know what the 13th edition is going to look like, or if I'll even be listed. Anyway, so that's the long story of how the book and why you don't have a 13th edition, and hopefully you will before much longer, because it's creeping through CDC clearance. But it's a major piece of work to get all those people to sign off on it, which is why I never did that. Because it never would have got published. It's out of date. Things I worked on the 13th edition before I left 2 years ago. So there's stuff in there that's 2 years old. And think about it, PCV 13 recommendation just made. That chapter, back to the subject matter expert, it'll never end. So I hope they just cut their losses sometime and just get it out.
So speaking of new recommendations, can you kind of help us out with the new meningococcal recommendations for infants? They're confusing. There are several different vaccines available. Does every infant need a meningococcal vaccine?
Well, the good news is that meningococcal vaccine isn't indicated for very many infants. And why? Infants, as you know, have the highest rates of meningococcal disease, but yet there's no vaccine routinely recommended for infants. And why do you suppose that is? Why?
B is most common.
Say again?
Because type B is the most
That's
common and
part
it's
of
not
it.
in the
That's
vaccine.
part of it, but there's even A, C, Y, and W. You know, C and Y do cause disease in infants, and they have the highest rates even for those. It's about money. It's about money. It's about cost benefit and how much would it cost. You ever been involved in the cost benefit analysis? Qualities, about the quality adjusted life years and how much does it cost to prevent one, to improve one. Anyway, it costs too much. It costs too much is the reason that there's no universal recommendation. But there's 2 vaccines that you can use for that subset of infants who are in fact indicated. And that would be who? That would be probably the biggest group may well be international travelers. Infants who are taken out of the country with their parents, would you say? Would that probably across the board? Is that because the other groups are kids without spleens, infants without spleens, and there's some of them with a terminal complement component deficiency. That's pretty rare. Maybe some immunosuppression. So those are the big ones. And there's 2 vaccines now that are approved for that use. In fact, one of which was almost specifically designed specifically for routine infant vaccines. That's the Glaxo vaccine that has C and Y and Hib in it. So you've got Menhibrix, which basically was designed specifically for U.S. use in infants. It's a 4-dose series. And then you've got Menvio, which was recently approved, not recently, but it's been a year or 2 since Menvio was approved for infants as well as a 4-dose series. So you're looking at basically 4 doses of either for U.S. Let me back up. You have to separate out international travel from other indications for meningococcal vaccine for infants because Menhibrix has only 2 of the 4 serotypes. It has only C and Y. Why is that important? Because A is the big player outside the U.S. If you go to Africa, the big player is serogroup A. Actually, even that is going down because there's now a serogroup A vaccine being used in Africa that is already showing improvement in the rates of serogroup A in certain African sub-Saharan countries. So Menhibrix does not have A. So you wouldn't want to count on that to protect an infant going to Africa. So for that, basically Menvio is the only vaccine up to age 9 months, in which case you can use Menactra in a 2-dose series for children who are 9 months and older. So for your traveling kids, you're looking at Menvio starting at 2 months of age, 4-dose series, or a Menactra at 9 months of age for a 2-dose series. If you've got another indication, asplenia for instance, then either of the 2 infant vaccines, either Menvio or Menhibrix, is okay. But again, Menhibrix is not good for a traveler because it does not have serogroup A, and you would leave the child unprotected. So if the child did get Menhibrix and now is being taken to sub-Saharan Africa for some reason, you would actually need to revaccinate that child with a vaccine age appropriate that actually does contain serogroup A because it's not present in Menhibrix.
So basically, we all have to stock at least 2 vaccines if we've got babies in that category.
I could argue that Menvio will cut it. Menvio will cover all of your indications. It doesn't have, so, you know, Menhibrix was essentially designed for use in the U.S. or, you know, non-Africa, not places where A was not an issue. But Menvio is approved for infants at 2 months of age and older, and it has all 4 serogroups in it. And so you're now, now 5 days, 6 days into the meningococcal serogroup B vaccine era, which just started on October 29th when FDA approved Trumemba. You heard about that. It's the first serogroup Trumemba. The PR people must have had a really fun time with that one. Trumemba for 10 to 25-year-olds. So that's the first vaccine we have that has serogroup B in it. There'll probably be another one before the year's over, but it's not for infants. It's not approved for Trumemba, the serogroup. It's Pfizer's serogroup B vaccine is not approved for infants yet. They probably will work on that, but it won't be for a while. Menvio is a 4-dose series. Menvio, how many doses if Menvio? Menvio is a 4-dose series if you begin at 2. And it's like other conjugate vaccines, which is the really confusing part, like pneumococcal conjugate, Hib, The older the child is, the fewer doses they need. And for that, you would need to go to a table. There's lots of tables out there that would tell you if the child starts at age 7 months, they get so many. If they start at age 9 months, they get so many. If they start at age 1, they get 2. So it depends on the child's age, which is the really confusing and difficult. If you've ever looked at the catch-up schedule, and I'm sure you have, in the childhood schedule, the conjugate, pneumo and hib are this much text, and everything else is about this much text. So all of the complicated rules are all for this dose by age issue that is present for all conjugate vaccines, including pneumococcal conjugate, or a meningococcal. So it's 4 doses. Starting at 2 months, it's 4 doses, 2, 4, 6, 12, like 12 to 15, like most of your other conjugate vaccines for babies.
Quiet audience. Do you want to jump into, oh, here we go.
Go right ahead. Go right ahead.
Okay, regarding healthcare, undocumented hepatitis B series for healthcare workers that got those in the late 80s, early 90s. I realize that the number one recommendation is a 3-dose series with a post-serological titer following. What about just the 1 dose that acts as a booster to kick in that immunological memory, and then a titer at 1 to 2 months? Because that's the answer I got back from NIPInfo. But there's just some controversy within our agency.
Well, that is actually a relatively new recommendation also about the management of remotely, and we knew this was going to be an issue. We've known it for 10 years, as all those babies that you started vaccinating in 1991 grew up to be nurses' aides and go to medical school and nursing school. So we knew this was eventually going to hit the fan, and it did. So last year, CDC's hepatitis group attempted to put together guidance on how to deal with this issue. And still the gold standard is still three documented, dated doses and serologic testing 1 to 2 months later. That's still the gold standard, but of course nowadays, when you've got all these remotely vaccinated people, medical students, nursing students, all these people who got vaccinated as children, they weren't tested because there's no recommendation for that. So what was recommended in this new set of hepatitis recommendations, and that's why you got the answer you did from NIPInfo, is because now to deal with that, the strategy that you suggested is exactly what is being recommended for people for whom you can, and this is the critical part, for whom you have documentation that they actually received 3 doses of hepatitis B vaccine, even if it was in 1991. So the key is, if it's not written down and dated, it doesn't count for nothing. You don't count them, you revaccinate them. You don't take their word for it, nothing. You basically have to show that they've been, and this is something that the hepatitis group at CDC has been very intent upon. Scenario, somebody walks in, they got no record, you test them, they're antibody positive. Is that person now considered immune or not? CDC says no, because the definition of immune means 3 documented doses and antibody positive, hepatitis B surface antibody positive, both, not one or the other, but both. So if your kids come in, and maybe some of them they've got records at home, I think children maybe have better records than all of us, I'm not sure. Registries, there's places you might be able to get their records. If they can document 3 doses, even if it was 20 years ago, and you test them routinely, because many of them will be positive, you test them, they're negative. The recommendation now, give them 1 dose. Give them 1 dose, which will give them an anamnestic boost. Test them 1 or 2 months later. Virtually all of these individuals who, in fact, were vaccinated as children will boost, and they'll all be positive, and you can stop. Or if it's easier, just give them 3 more. But bottom line is, if they've already got 3 documented, most of them will have responded, but the antibody levels do fall over time, and that is exactly what is being recommended now, that exact strategy. But again, it's dependent on them being able to document that they actually were vaccinated before. So you want to make that should be the first thing they have to do, is show you written, dated evidence that they actually got 3 doses at some time in their life.
So in undocumented, then just the complete series.
Start them over 3 and revaccinate. No documentation means no vaccination, and that's pretty much universal for all the vaccines we use, with 2 exceptions. 2 exceptions are pneumococcals 1, you take your word for it, which I don't think we should, but that's the recommendation. The other being flu vaccine. Flu vaccine, if they said they got it, you take your word for that. That's the only 2 exceptions to, if it's not written, you don't count it. Otherwise, if they can't provide written documentation, it doesn't count. Now, granted, and again, this is one real weird situation where I actually had some issues with the hepatitis people who, if somebody comes in and they test clearly antibody positive, they have hepatitis B surface antibody, and it's 150 milli international units. The current recommendation is you do not consider them to be immune unless they can show you the documentation of their vaccination. I have some philosophic issues with that because it seems like they ought to be immune, but I'm towing the line on this one because I'll get in trouble with the hepatitis people at CDC if I do. If I say, because that is the formal recommendation, you've got to have written documentation of vaccination and antibody positive. That makes you immune, and you're permanently done. By the way, once you have hit those two things, you're out. You don't have to have any more testing. You don't have to have any more anything. No booster doses, no nothing. 3 doses and antibody positive, and you're done for life, based on current knowledge. If 6 doses, what if they never seroconvert? So you've got somebody now with 6 documented doses, and they still test hepatitis B surface antibody negative. By CDC's definition, that person is a non-responder, and there's now a whole algorithm about how to deal with non-responders. However, and so that is the party line. The party line is no more. That's it, 6, and you're out. And you then get treated as a non-responder. And again, these recommendations were published a year ago. The new document that talked about management of needle stick exposures, and there were some other things in there. So you might want to, if you're in a position to have to work with those kind of folks in post-exposure situations, you might want to get a copy of those if you haven't already. But there are people who feel strongly that not at CDC, there are guidelines out there for other things to try to coerce a person's immune system into developing an immune response. For instance, changing brands, or using a dialysis dose, or giving a couple more doses, or giving it sub-Q. I mean, there's all kinds of things that have been tried. There's actually a big literature out there in the infection control literature about how to manage non-responders to hepatitis B. It's on the front burner of most everybody who works in infection control about your non-responders, and there have been things written about just anecdotally how people have been given additional doses of vaccine, or more doses of vaccine, or changing the brand of vaccine, or changing the route that the antigen is given to the. These are all kind of off-label-ish things, but frankly, I have to be honest, if I was in charge of infection control or hospital employee health, I think it's incumbent that everybody, you go make maximum effort to try to make sure everybody's protected. If that means an extra dose or 2 of vaccine, or give them another way, you'd want to discuss it with them and explain why you're doing this. And again, there's literature out there to support those kind of approaches, so you can see those. But by CDC's definition, 6 doses, you're done, and that's all you get. I think I'd ask for a couple more. There's one behind you. I'd want to have antibody. If I was out there working with sharps, I think you want to have hepatitis B surface antibody. Yes, ma'am.
Okay, so on the 14-15 minimal immunization requirements for children for school, there is a new deal, which we knew it was coming out, that they have to have 2 MMRs. We've had a couple of kids come in our clinic in the past 2 weeks from foreign countries that have had measles, mumps, and rubella, but independent shots after a year old. Yet the school nurses are still sending them in saying, no, they have to have an MMR. But there's nothing written in that documentation that says that you can accept them as different components. It says 2 MMRs.
Well, far be it from me to comment on your school rules, but that does seem kind of odd. Because obviously, now clearly it's all dependent on documentation. If it's clearly a documented dose of measles vaccine and mumps vaccine and rubella, and it's dated, and you know it's after the first birthday, 1 dose of each of those counts as 1. No, they're not throwing it back to you because they need 2 of each, right? They're throwing it back because the person.
Yes, but they're sending them in, and they've already had another MMR given as well.
Oh, and they're not counting the single antigen vaccines?
Exactly.
Well, that's not correct. That's somebody needs to look into that, because if they are documented and they're dated and they were given on or after the first birthday, those are valid doses. And I'm surprised that Texas would have a rule
and it's
otherwise.
Literally in black and white on the Texas Department of Health website And it says 2 MMRs, and there's nothing written below that states that you can accept them individually. And so it's how the school nurses are interpreting it, and I get that. I'm a school nurse as well.
You
but
might want to appeal to somebody in the immunization program in Texas to clarify that, because clearly that is a misunderstanding or a misinterpretation, because you should not be having to give third doses of everything to everyone, assuming all the caveats that they were all written documentation, they're all dated, they're all up to the first birthday. There is absolutely no reason why those vaccine doses shouldn't count.
Just two quick comments on that. That's a good thing for the Immunization Partnership to do some advocacy on getting the rule change written. So make that as a comment on your conference comments. And secondly, that a physician can often convince a school nurse by just writing a note saying, this is adequate, we're not giving another one. And often that will do it. So that can happen with spacing.
Yeah, it may just actually
In a
require
public
just
clinic,
a
it's
clarification.
harder, yeah.
It may just require a clarification, not even a rule change. So it sounds like it's
Right.
it's an interpretation issue more so than anything else. So.
Can I make a comment? The minimum requirements is like the Cliff Notes version of the requirements. Actually read the TAC code, and it will clarify in there that the single dose with a second MMR is actually fine. So you actually need to read the TAC code. Yeah, so yes, the Texas Administrative Code, and it's like, what, 97.6? Something like that. So yeah, the TAC code actually spells it out. Actually, call Austin. There's a school compliance person, and they'll find it for you.
So I noticed the new revised VIS came out for your baby's first vaccines, and rotavirus isn't on there anymore. You know why?
Say what?
The rotavirus is not listed on the VIS form for your baby's first vaccines because they revised it and they took it off. Curious.
Is the revised version out yet?
October 22nd.
It actually has been published?
Yeah, October 22nd.
And there's not some kind of a caveat on there?
Nope.
That,
It's not on there.
well, how odd is that? And that's actually the person that does those was working for me when I was there. I didn't know that. I haven't seen it, and I did not know. Can we collaborative evidence on that? Yes, lots of yeses. It's not, so rotavirus is not listed on the this is the multi-vaccine VIS. I will have to ask about that because I did not know. I can't think of any reason why it wouldn't be, because obviously rotavirus vaccine is still recommended routinely, so that hasn't changed. So those things go through so many hands. You cannot believe what it takes to revise a VIS. It has to literally go to Congress and back, which is why it takes a while to get them formally revised. So I'll have to inquire on that. I did not know. So that's strange, and there's no note on it. There's no footnote that says, "Oh yes, and also rotavirus used a separate." What's that? Oh, so it does. There is something it says that refers you to the rotavirus one separately. Okay. Well, I have no idea why they would have dropped it off unless it was the rotavirus people who did it. So,
I think the information that came out with the VIS,
I don't remember which email or publication where it came from, but when they sent out the information about the new baby VIS with all the multiple vaccines, they said to give the rotavirus one separately because it's so specific as to when you can and can't give it, and you have so many kids that are behind that you can't give it to.
that would make sense, because
and I think
that's one of the big exceptions, which is one of the strange exceptions about rotavirus, is that you age out. You age out at 9 months. So that's a big difference between that and all the other vaccines, which may well be the reason they split it out.
and it's also the SCID, the severe combined immune deficiency risk. So they want to make sure that
a
that's
unique vaccine.
Yeah.
That
Next
is
question.
probably why. Because probably there wasn't enough. I'm sure it's cluttered as it is. It's probably got lots of words on it as it is, and to add all the caveats for rotavirus would have made it probably unreadable, like the footnotes on the schedule.
Can you talk a little bit about flu vaccine and nasal flu vaccine and why it's preferred for kids and why it wouldn't be preferred for adults?
That's fairly straightforward answer to that is because the reason, and this is the first time, by the way, you have all seen a historic event in the history of ACIP for the first time ever with all this burgeoning numbers and types of influenza vaccine that we actually have a preference statement for one specifically, for one group. There never has been before. It's always been do what you want within the age limitations. But in the what now, nearly 10 years since we've had LAIV, flu mist, there have been now 2 studies that have clearly shown head-to-head flu mist injectable vaccine that have shown that in children through age 8, 2 through 8, the vaccine actually protects better, significantly better than does the inactivated vaccine. Now, that's not to say that the inactivated vaccine doesn't protect children. It does. It's just that LAIV protects them better, about 25% better. So that's why, and lots of other things that, like the manufacturer being capable of making enough to supply the whole country's 2 to 8 year olds. There's several factors involved, but that's why they made a preferential statement, because clearly the vaccine is superior in protection against medically attended respiratory infections in children up through age 8. The problem is that has not, and that's always the next question, well, what about adults? Well, the problem is that has been attempted. That has been looked at with adults and older children, but the data are not nearly so clear, and I can't give you a reason why. Both vaccines work about the same. For people who are up through age 49, they have looked at head-to-head, and it looks like they both work about the same. So there's this difference in efficacy or protection has not been seen in people over the age of 9. Presumably, it would have to do with something with all the antigenic accumulation that we've all had because we've all been vaccinated or infected repeatedly, something about that. And but that difference, that benefit, that superiority, if you will, has not been seen for older children or adults. Hence, that's why the recommendation stops at age 9. Important thing, though, is hopefully you've all got LAIV for your pediatric patients up through age 9. If you don't have it, don't send them packing without a dose of something. So vaccinate them, even if you don't, for your supply ran short or didn't come in when you thought or whatever it is. If they're in your office, don't let them out without a dose of something. Preferably LAIV, but if you don't have that, use the inactivated vaccine if that's what you have in stock at that moment. So don't miss the chance, because there's the same old thing. There's no assurance they'll come back. Take advantage of them having keep your LAV in stock. That's the trick.
Okay. Well, I've got a bunch of questions. I guess I can keep. You guys aren't going to talk.
Can I expand on that? Do a slight expansion on that. A common question we've gotten is that for one reason or another, a 5-year-old came in and got a dose of inactivated vaccine. And then mom goes home, or dad or whoever goes home and finds out that, in fact, it was the flu mist that was recommended, not the injection. And so they come back wanting a dose of LAIV. The recommendation is 1 dose a year. Particularly, there are rules about how many doses, of course. If the child had gotten, that was their second dose, or they had been vaccinated last year, only 1 dose is recommended for those. So you would not give that child a dose of LAIV if for some reason they got a dose of inactivated vaccine at another provider or someplace else. The other place we see this all the time is with, I won't say senior because I'm too close to that now and I don't like that word. For people 65 and older, who I assume you know that there's now a specific vaccine license for those people, which clearly does protect better. High dose, Fluzone high dose protects better, and there's clinical data now that shows that it protects better than regular standard Fluzone, which is where it was tested against. You give them a dose of regular, this 70-year-old comes in, you give them a regular dose of Fluzone, they go home, they find out about the high-dose vaccine, they come back and they want a dose of that too. That is also not recommended to repeat that dose either. But I'm hoping maybe we'll see a preferential, because now there's fairly clear evidence that the high-dose vaccine does protect people 65 and older better than the standard dose. And it's got a lot more antigen in it, so it's got a little more local effects and that kind of thing. Costs a little bit more, I think. But it does seem to protect them better.
Okay, now that we're talking about the older adult, I have a question about the shingles vaccine, and this is specifically for my former roommate. She's 61. She has rheumatoid arthritis and Sjogren's, and so she is on a medication, and I can't remember the name of it, but for having these autoimmune disease. diseases. Now she's up around perfectly healthy. Everything's under control with this. She has had shingles twice in the past 5 years. One a really bad case where she was out of work for a month, and then the second time she recognized the symptoms right away and got medication, so it didn't linger. But she went to her doctor for her last physical and said, "Should I get the vaccine?" And the doctor said, "I don't know."
That's probably the most, that and permutations of it is probably the most common question we get about zoster vaccine, about this whole immunosuppression being a contraindication. And as you know, the definition of immunosuppression now, there's so many things that can or could potentially cause immunosuppression. It's almost impossible to list them all out or come up with all the permutations. Generally what is said is we try to, well, let me give you a little background. Back in 2005-06, when these recommendations were first beginning to get put together, I was on that work group too, and we actually tried to make a case to ACIP that actually immunosuppression should be an indication for zoster vaccine, because it turns out that you don't really lose your immunity. If you've actually had chickenpox, you don't become unimmune to chickenpox because you are immunosuppressed. Evidence. Think of all the people you know take steroids or Enbrel or all these different drugs. They don't get chickenpox again. They might get zoster, but they don't get chickenpox. You don't lose your acquired immunity to varicella. And so it might be beneficial to give those folks a dose of zoster vaccine, even if they're immunosuppressed, because they're very unlikely, because remember, we're giving it to somebody who's already had chickenpox. So they're already immune. This is unlike basically any other vaccine that we do, any other strategy. But ACIP couldn't do that. It was just too weird for them. And because it just was so out of touch, it was so different than all the other rules, there is some attempt at consistency. And live vaccine plus immunosuppression means no vaccine. That's it. It means that for all, there's really no exceptions to that, with the possibility of yellow fever and certain people who are going to Africa, that kind of thing. So they couldn't think that through, and so that was tabled right off the bat. And they didn't want to go there. But the fact is that lots of people with all sorts of sort of this whole gradient of immunosuppression have been given zoster vaccine over the last 10 years that we've had zoster vaccine, and I'm not aware of any severe reaction in really anybody who's gotten zoster vaccine, with the occasional allergy, but that's very unusual. So if you read the recommendations, there's all this wording about this drug and that drug, and whether you should or should not do it. The fact is, there's probably a pretty big margin of safety for this vaccine, given who we're giving it to. That is, people who are already immune. The recommendation is, if they're immunosuppressed, don't give them the vaccine. The problem is there's no definition of what that means. That's the problem, because you can't. ACIP certainly couldn't come up with it'd be encyclopedic, all the different ways that a person could be immunosuppressed, and then there's permutations of all those, how much drug, how many days, how long will they be on it, all this stuff. And so they just made this blanket statement and then said, talk to the clinician, and the clinic throw it right in the lap of the clinician, saying, do you consider the person to be significantly clinically immunosuppressed? And think about that. How do you do that? Well, are they having thrush? Are they having repeated infections? Talk to your ID guys. Do you think, granted they're taking an immunosuppressive drug, but are they really immunosuppressed to the point where they're having opportunistic infections and things of that nature? So that's what they did, is threw it back to the clinician to make the judgment call about whether the drugs this individual's taken for whatever indication are sufficient to cause significant immunosuppression in that person, and if not, then give them the vaccine. And so basically it comes down to that, and it would very much depend on what, usually the drugs for autoimmune disease, Crohn's, lupus, RA, those kinds of things, are usually lesser than people who are getting chemo, and transplant suppression, that sort of thing. So but again, it's a wide spectrum of different kinds of immunosuppression, and you have to use some clinical judgment about whether the drugs this person is taking at this dosage for this long is really causing them to be significantly immunosuppressed. Granted, it may be reducing the symptoms of their lupus or Crohn's or whatever they have, but it may not be enough to create concerns for adverse events, which is the back of the brain. Very common thing, very tough to go through because a lot of folks are kind of skittish about doing that. So to get out of it completely, what you try to do is get them off the drug for a little while, if at all possible. Try to wean the drug down, get them off the drug for a few weeks, give them the vaccine, and then start them back up if they need it. That's the cleanest way to do it, and that's usually what's done, as opposed to trying to judge how immunosuppressed is this person, because there isn't any really good way to do that, except really kind of gross things like oral thrush, recurrent infections, that kind of thing, which are not good indicators probably.
We have about 15 more minutes.
Everyone.
Hi. So the HPV vaccine has been recommended for teenagers and young adults, both boys and girls. What about for adults who are over the age of 26?
I love that question. And these are the kind of things I couldn't talk about when I worked for CDC. Here's the deal. Let me give you the big picture. Why does any vaccine have age limits? Have you noticed? All of them do. All of them have some kind of age, at least all of the recent vaccines. The old ones don't, like MMR hasn't ever been tested in 80-year-olds, but it's recommended for anybody a year old or older. But why is it? And I think I heard it. It's because of the way, it's the data that the company, it's the study, the way the study was done, because FDA is very rigid these days and will only give a vaccine approval for the age group and gender for which they can provide safety and immunogenicity data. And it turns out that the study, the key, massive, huge study that Merck did and Glaxo were done in people up through age 25, 26. And the problem is Merck actually tried to they did a study in older women up to 45, and they had problems doing it because, how can I say this tactfully? As we age, now I'm not talking about any specific person here. As we get older, we accumulate the history of all the HPV we've ever been exposed to. And as we get older, we tend to have increasing numbers of exposures. Not everyone, but some people. And it becomes harder. It becomes harder to find individuals who have not been infected. So as you get older, it gets much more difficult to find somebody who's never been infected to any of the strains. And that's really what you need. You need a completely HPV naive group who have no immunity to anything, and then you need some with 1 or 2 or 3. And that's how you really do your test. And that was very hard to do, and they really couldn't show, there was no safety issue, but they had a harder time showing immunogenicity and prevention because of issues about the population. And so they actually didn't get a license, they didn't approve that particular indication. Now, with that background, that's how the study was done. It was done in up to 25-year-olds for Cervarix, up to 26-year-olds in girls and boys for Gardasil. And likewise with the new vaccine, the HPV-9 that may well be licensed before this year is over, that they also, only in girls, basically 9 through 26. So that's who the recommendation's for, because ACIP gets very nervous, and so does FDA, who sits in the same room during the ACIP meetings. FDA is sitting right there, and they get real upset when ACIP makes off-label recommendations. But ACIP has been known to make off-label recommendations, like, for instance, giving Menactra to people older than 55. For instance, that's off-label. Giving Adacel to people over 65, that's off-label. And it's rational to do that, but FDA people get all nervous because, they say, where's your data to show that it's safe and effective? So with all that as background, you do have people who have indications for, two situations. One is that a person has begun their series at 26 years of age or younger. And ACIP is on, or at least CDC, not ACIP, but CDC is on record as recommending that if the series was begun at age 26 or younger, it can be completed after the person is 26, no matter how old they are. So that is on the books already. So that is technically off-label, and CDC kind of put that in there. But what if you have, in reality, you may have situations where you have an individual who is older than 26, who has never gotten a dose, who has, say, changed his or her social status and may be dating again after many years of not, and may have a very justifiable concern about HPV, and has a low probability of having maybe had 1 or 2 partners, as far as she knows or he knows, and so it might be a good candidate for somebody who might be exposed, and you'd like to protect that individual. FDA has always said that they are not the vaccine police, and CDC and ACIP has said they are not the vaccine police, and there are no vaccine police. That if in your clinical judgment, the vaccine, after a discussion with the patient, if you believe and the patient believes that the vaccine is in the benefit of that patient, there is no reason whatsoever why you couldn't give them that vaccine, even if they have aged beyond the upper limit. What you have to tell the individual is that, well, the studies were all done in younger people, but it's an inactivated vaccine, and so we can't really guarantee it works as well. We know there's data about safety, and it's not a safety issue at all. And I think what you have to do is basically discuss it with the patient, and if you think and they think that it's beneficial to them, please do. I certainly would, if I was in practice and had a 30-year-old who was back in the market and was possibly being exposed to HPV by whatever reason. I think I would seriously consider recommending it for that individual. Why would you not? I mean, why would you not? And so here's the downside, though, for reality check is that insurance, the payment system usually mimics or goes along with what ACIP recommends. So you have to tell them, number one, we can't really assure you that the vaccine works, but it probably does. We know the vaccine is not unsafe. It's not like a safety issue, but you're outside of the age that's recommended by ACIP. Consequently, insurance companies tend to think very rigidly about these things, and they may deny payment. They might not, depending on the insurance. So that's the thing they have to understand. But one could argue, I could make a strong case that paying $500 for 3 doses of HPV vaccine probably is cheaper than a single colposcopy. Not that I know anything about colposcopies, but one procedure eclipses what it costs for a 3-dose series, and if you could reduce that risk, to me, it's absolutely justified to do that. But they have to know that their insurance is probably going to deny them. But again, you need to put it in perspective that this is, particularly with HPV-9, that's going to extend us from 70% of oncogenic strains to 90% of oncogenic strains, and that vaccine hopefully will be out before the end of the year. Gardasil 9. I'm not sure what they're going to call it, but it's a new, improved Merck vaccine that has seven oncogenic strains instead of the 2 that are currently in the vaccine. It's going to start out approved for females. Now, ACIP hasn't, because that's the same way that Gardasil was, if you remember. Started with girls, then went to boys after they finished the study. Well, the girls' study for HPV-9 has been finished, and that's what they submitted to FDA. So FDA, being concrete in their thinking, is going to approve it for girls, for females, 9 through 26. Male study will come along, but as the discussion happened 2 weeks ago in ACIP, I believe that ACIP is going to recommend it for both boys and girls right off the bat, because it's just a matter of time before the male study comes. So they're going to go off-label for gender for this one. Again, those haven't been approved yet, but that's the discussion that took place last week. That's the way I think they're pointing.
One last question.
It's another HPV-related question. I know a few years ago we had a little controversy here in Texas where our governor wanted to make HPV one of the required vaccines for school, and that didn't go over. I'm just wondering what your opinion is, if that should be one of the required vaccines or something that should be left to parents.
Well, there's a philosophical issue, about requirements or not, and one could argue that school laws, really requirements, ought to be for conditions that, in fact, that attendance at school puts them at risk for. And obviously all of our airborne or particle-borne diseases are like that. HPV falls into a weird category because it's not exactly something you would expect to be transmitted in a school setting. That doesn't mean that it's not. Now, you could argue for hepatitis B vaccine. Well, hepatitis B is neither. Well, yes, it is, because you can bleed on the playground and get exposed to hepatitis B. I personally am a big fan on anything that will improve vaccination levels. I think there probably is a good way to do it if we get the right message to parents and have them understand this is not about sex, this is about cancer, and we could do better, and the reimbursement process would better. I think we could probably do the job that way, but frankly, history has shown us that when things get put into, when you make it a requirement for something, levels go up rather remarkably. And I think if that's what it takes, frankly, to save girls' lives when they're 20 years old, so be it. And that's just my opinion. I do not work for CDC. This does not represent anybody's opinion except mine. We do what you have to do. If that's what it's going to take to get parents off their butts and get them in there and get the vaccine into their children, that's going to save their lives 10 or 15 years hence. Why would we not do that? I mean, you've got the libertarian way to look at it, and you've got the public health way to look at it. And I think from a public health standpoint, I would vote for it because it would improve vaccination levels. And if that's what it takes, then that's what we should do. But again, it's off to a hard sell, and there's a lot of people who still have major misconceptions about HPV vaccine, as you know. So.
Thank you all for coming. I think we have about 5 minutes before the next session, so I held you over. I apologize for that.
Pardon?